Welcome back to the next episode. I'm Travis Brashear with Lockton, and we're talking about people solutions. And as I've said in the past, as a tee up to some of these, we're talking to people and getting to know people behind the scenes. We're also talking about solutions and things that we're doing both within our traditional benefits and healthcare practice and outside of that. And today we're excited to be joined by Dr. Christine Hale, who wears a lot of hats within Lockton, but also runs a complex claims unit, which has become a really big deal. So Christine, thank you. Welcome.
Thank you so much. Delighted to be here with you.
Thanks. Well, let's talk a little bit about just your background. I know Dr. Hale, obviously we get that part, but how did you get into this space, and what gets you out of bed every morning?
Yeah, absolutely. Well, it certainly has been a serpentine career path as opposed to linear, but I think that adds real richness to the work that we do every day. So, of course, started as a pediatrician and stayed at Duke and got an MBA after I finished my medical training. And serendipitously got a call from McKinsey and Company to become a consultant with them, which I thought would be a great learning experience if I wanted to affect change in the healthcare system.
Right.
Thought I would go for a couple years. I loved it. I ended up staying almost 8 years. And then I went on disability, and I was full-time patient for 15 months. And I will tell you, I had no idea what healthcare really was like for patients until I had to deal with my own rare condition.
Yeah.
And that experience really shaped the rest of my career. It really drove me to want to get back closer to impacting specific members. I first came then to a health system, a national health system, and did work on cost containment and quality improvement for 4 years.
Okay.
Had the great opportunity to join Lockton almost 7 years ago now.
It's been that long?
Yeah, it really has. Time flies.
I think I met you maybe with an outside vendor back then,
right?
Like your first week.
Probably so. Yeah, it was pretty early.
It's a long time ago.
Yeah.
So it's been an interesting 7 years for sure. But talk a little bit about what was the impetus for you coming on board? What was Lockton looking at when they said we really got to do something differently?
Yeah, great question. And again, serendipity is always my best friend. So I had a recruiter actually reach out. So at the time, Lockton had a medical director that was retiring. They were looking for a replacement. This recruiter knew me very well and said, I think you'd be a great fit. And I was looking at him like, you've got to be crazy. I know nothing about benefits. And he said, actually, they're really innovating in the space and doing a lot of creative work. I think you should just at least go talk to them. And I will say it's 2 hours of discussion with Lockton, and I was like, sign me up and put me in, coach, because what the team was doing was really starting to impact member-specific issues that are driving a lot of the claims costs.
Yep.
And because of that, you're also impacting the member experience. So it's that real impact on patients. And that's why we all go into healthcare in the first place, right? Is to help people. So this was a really unique way for me to get to help people and save money at the same time. And not everybody can say that they can do that.
Yeah. So tell me about the unit that you've created, starting probably with you as number one.
I was number four, actually.
Number four,
believe it or
okay.
not. Yes. So it was a small but mighty team when I joined 7 years ago. The practice started with an underwriter from UHC, a case manager, a nurse, and a coding and claims expert. And I was number four as the medical director. And we now are close to 30 dedicated individuals that all we do every day is put on our private detective hats and go in and look at individual members' claims, whether they're currently high cost or likely to head that direction, and try to find solutions that will help that specific member.
When we step in, talk a little bit about sort of that spectrum of, we're looking at the claim itself and we're looking all the way to, do they have the right provider? Talk a little bit about what you see where the opportunity lies.
Yeah, well, if I can back up just one step, which is how do we open a case, right? That's kind of the first question. And as the audience may not be aware or may be aware that this is a tiny fraction. We're talking 0.5 to 1% of the members that typically drive about a third of plan costs.
Yeah, that's great.
I call them the purple zebra unicorns. They are truly the exceptions, which is why population health solutions are fantastic, but they're not necessarily going to be able
Not
to
gonna
address
fix
this
this.
level of complexity.
Right.
So the three ways that we will open a case, one is sheer dollar amount or change in the trajectory, right? If somebody's ticking along at a certain level, we see a big bump in their claims costs, we're going to start asking what's going on.
Yeah.
The second way, which has really been our focus the last 2 years, is we've built out, so InfoLock is our data warehouse, and it has claim level detail on these individuals. My team are the only ones at Lockton that can see that level of detail.
Right.
But because we have that data, we've built out now almost 7,000 triggers that flag cases on first dollar claims basis. So the first time we see a drug diagnosis mismatch or we see a cost that's out of line for a service and we're wondering why, a lot of those are now coming in through these flags or triggers in the system.
Wow.
The third and maybe my favorite way is because through direct referrals from case managers, navigators, and even benefits team members. So sometimes an individual, the first sign that they're struggling and are about to hit some road bumps is they're asking about short-term disability, they're asking about FMLA. That certainly was my case. The train was about to run off the tracks and I just couldn't work anymore. And that was really the first sign. So we always encourage folks, if they see somebody who's really struggling to get through the system, to give us a heads up and see if we can help. There's really two main components to our work. So the first is the cost projections that we do. This is the piece that finance often loves because it really helps hone those projections for budgeting and those purposes. But the part we get really passionate about is the go get it, where we do try to actually impact the outcome of the case clinically and from a quality perspective, but also obviously from a cost reduction status.
Right.
So we're going to start when we open that case all the way at the beginning and say, is this, do they have a correct and complete set of diagnoses even? Some of our biggest savings have been getting people to some of our referral destinations and getting the right diagnosis so they can get the right treatment. We've had cases where someone had a diagnosis of MS and they are on a $300,000 a year medication. Turns out they don't have MS. That creates a problem with both A, cost that's not adding any benefit, but B, they're not getting the treatment that would actually help them, right? Once we're comfortable with that, we're going to ask questions around the clinical appropriateness of the treatment. Maybe they need access to a clinical trial and we can help with that. But the real cost savings comes in the looking at ways that care can be rendered that are not necessarily the traditional way, but make a better member experience and save money. So that's going to be things like doing that infusion in the member's home instead of in a hospital, such things. And then there is the claim is not right. So we're going to do the I dotting and the T crossing, looking at the itemized bill, medical records if needed, and just making sure that someone you'd be maybe amazed at how often it is that we see that somebody fat fingered an extra zero on that bill or coded something incorrectly. And so, having that extra set of eyes to make sure that whether it was deliberate or not deliberate, that somebody's taking a look and making sure everything was correct.
Yeah, because at the end of the day, these are humans, right? And they're also, in a lot of cases, really highly important, productive employees, and they're in a really bad place. And so that, at the end of the day, sort of what, as you said, gets us out of bed. But do you have a couple of favorites that you want to share with the group?
Yeah, these are my favorite stories. And there's one gentleman that comes to mind immediately. We were contacted by his employer, by the benefits team, and said, this just doesn't look right. This poor gentleman is in and out of the hospital. He's had multiple brain biopsies and other very invasive procedures. Wow. Poor thing had a history over the prior year of being told first that he had a stroke. Then they said, that's not actually what's going on. We think you have cancer, brain cancer. And then they ended up doing a biopsy and said, well, it's not cancer. We think now that it was maybe an amoeba infection, a rare brain infection, but we can't tell what organism, so we don't know how to treat it. Meanwhile, he's having progressive loss of his neurologic function, having trouble walking, speaking, writing, everything. And he eventually was told, we don't know what this is. We don't know how to treat it. And you should plan for end of life
Are you serious?
It was that bad as he was deteriorating. So we were able to fast track him into one of our partners, the Mayo Clinic at their Florida location. Within 3 days, they figured out that he had a super rare form of multiple sclerosis. So rare that I had to look it up. Didn't learn about it in med school.
Wow.
And they had a great treatment plan. He had the great fortune to live in South Florida, close to another partner of ours, Cleveland Clinic. So we got him in there for ongoing management.
Okay.
And he is back at work, regained his function, and he wrote a letter for their newsletter, their company-wide newsletter, just saying, I want people to know that this is out there because it saved my life.
All right, so that's one. You said you had two. Share one more.
Well, I have one that's very relevant because the member just messaged us yesterday. And this just goes to show how many ways that the healthcare system can go off the rails if you're not paying attention. So we have another client that I was reviewing their data. So I had pulled all the data on their claimants over 100,000 just to see what other trends we could find, and stumbled upon this case that I literally had never seen before. So it was a gentleman who has a severe bowel condition, autoimmune, called Crohn's disease.
Yep.
That in and of itself is not rare. What's rare is that he wasn't getting any kind of regular treatment or prevention for this, and had gotten so severe that he ended up in the hospital with kidney damage because he was losing a lot of fluid and got dehydrated.
Oh, wow.
So it had just gone out of control. Well, furthermore, when he was discharged from the hospital, they put him on IV normal saline, which for non-clinicians is basically hydration fluid. There's nothing fancy about it. It's the stuff you can get at like a mall clinic, right? For a couple $100. And he was getting it though in a hospital setting several times a week at the cost of $150,000 a year. It's salt water.
Yeah,
It was like, I've never seen anyone on regular saline infusions for 3 years, and B, I've never seen it done in a hospital for $150,000.
Wow.
Furthermore, when I talked to the member and his provider, they both had requested it be done at home and were told there were no in-network options for them. So it took us a year, but we finally got an in-home provider. He is now, not only is he now getting the infusions at home, but they trained him to do it himself.
Oh, wow.
And he is so happy, and the new cost is $30,000 a year.
Okay.
And then we're going to refer him to one of our expert partners to manage his Crohn's disease. But it just goes to show you, member impact. He's much happier. It's much more convenient. He doesn't have to miss work to go to the hospital. He does it at night when he's at home, and he's happy. Cost is going down, and he'll get better care.
Well, thank you for being here and taking the time to help us get some clarity around what we're doing. If you're listening today and you have an interest and a need to address so your highest cost claims, your complex claims, know that we've got this model out here. Dr. Hale's always on the phone talking to people about it. If you want to just have a conversation, reach out to me or Dr. Hale. And thanks for joining, and we'll see you on the next episode.